Good morning. Welcome to another edition of McMaster Perspective. Again, we are welcoming Professor Michael Sharma, the medical director of the stroke program and the chair in stroke prevention. Professor Sharma, the blood pressure management, both in primary but mostly in secondary prevention of the strokes, and that includes both ischemic type of stroke and hemorrhagic type of stroke. There is always discussion around it when the patient shows up. Could you please comment on blood pressure management at the time of stroke?
So it's a great question. Hypertension is the most significant cause of stroke of both types, ischemic stroke and hemorrhage. Hypertension results in atrial fibrillation, large artery disease, small artery disease, as well as intracerebral hemorrhage. One thing to remember is reducing blood pressure, systolic pressure by 10 millimeters of mercury, reduces recurrent stroke risk by 40%. So it's a very potent weapon in our armamentarium to reduce the risk of recurrent stroke. All categories of antihypertensives have that effect except for beta blockers. Beta blockers don't seem to be associated with stroke reduction. They're not really first line or even second line, so it becomes a bit of a smaller factor. The questions that really concern clinicians when they're dealing with stroke patients is how soon after the acute event to reduce the blood pressure, when is it safe, and what targets? And I'll give it in three categories. The first and easiest is when you have intracerebral hemorrhage. Where we have arrived now is that blood pressure should be reduced as quickly as feasible in the ED to, for most patients, under 140 systolic. So that is the target. In years past, we were concerned that around the hematoma, there might be some ischemia that we would exacerbate. That's not proven to be the case. What it seems to do is decrease the chance of that hematoma expanding and the patient deteriorating. So, and most stroke centers are in the process of implementing very rapid treatment. As you can imagine, it requires some urgency in the ED. It requires a setting where you can monitor the blood pressure consistently. For ischemic stroke, it is divided into two things. Now, first off, the vast majority of patients with acute ischemic stroke have high blood pressure. The higher the blood pressure, interestingly, the worse the outcomes. If you look at trials in ischemic stroke, which say, if we reduce the blood pressure quickly, does outcome improve? The answer is no. So in spite of this observation that higher blood pressures are associated with worse outcomes, treating it very early doesn't seem to benefit the patient. The guidelines that we have right now, first are if you have had thrombolysis, then really that blood pressure prior to thrombolysis and afterwards for 24 hours, you want to keep under 185 systolic, 105 diastolic. So that needs to be monitored because the risk of hemorrhage is greater. If you have not had thrombolysis, the current guideline says that you shouldn't intervene until it is above 210 on 110. Now, as you can imagine, that's quite a high blood pressure. The reason for that has been the lack of benefit in these trials with early blood pressure lowering and the ongoing concern about worsening the ischemia. And you can worsen the ischemia if you can imagine a vascular occlusion where the brain is surviving on collateral blood flow, and you suddenly drop the pressure, the collaterals fail, and the infarct expands, large vessel occlusion. So, without knowing all of those, that's the reason the guideline is set high. With most patients who are hypertensive before their stroke, you can restart their home blood pressure medications in a day or so, and the blood pressure will improve. Usually by 3 days, that acute hypertensive response has decreased. After about 2 days, I am quite comfortable starting blood pressure medication. The trials that we've done of very early treatment in the setting of ischemic stroke haven't shown much hazard. So usually by 2 days, we've established whether there's an occlusion, we've established if there's a lot of stenosis in their vessels that we might be worried about, and we're comfortable. If you don't have that detailed vascular imaging, it's still probably quite safe by 2-3 days to treat that blood pressure and get it down. And then over the long term, that blood pressure, the targets are exactly as we have for primary prevention, generally less than 140 on 90. And again, some patients believe that if they get to 140, they're perfect and there's no added benefit. And of course, that's not true. The lower below that, the better. It's really a straight line response to getting a reduction in the risk of stroke recurrence.
So the question which generates so much discussion over the last 5 years, how low?
So
and we can achieve it safely.
This is a really good question. So I had a mentor once who said, you should get it so low that the patient feels dizzy. Now, I'm not quite sure that that is the best strategy. The evidence that we have right now is that, so there was a nice trial done in the US with some cognitive outcomes. And the suggestion was the lower target, which there was less than 130, closer to 120. In those patients, they had fewer instances of mild cognitive impairment. Now, one thing to know is those were secondary outcomes. And in that trial, the population was really pretty healthy. So these were people who didn't have vascular disease, who didn't have untreatable hypertension, where you could get it down quite low, didn't experience postural hypotension. So, I think the short answer to your question is we don't know the optimal. What we've seen, and it's similar to what's been seen by lipids, is the lower you push it, the more benefit. The difference between LDL and blood pressure is when it gets quite low, we do see some hazard. So, where I start to become a little concerned in older patients is when it gets to be about 120. Doesn't mean that I change things. The one thing I do like is when patients measure their blood pressure and I can reassure them and their family physician that they feel perfectly well at blood pressures of 110. Sometimes there's a temptation. You treat the patient, say months out from the stroke, blood pressure is 110, and the family physician might say, well, that's too low, and I'm going to stop it. But the evidence would suggest that's better than 120 or 130, and if they're tolerating it, why reduce the medication?
Well, that is very helpful. Maybe my last technical question: emergency room, hypertensive, bleed, blood pressure high. You mentioned get it down as soon as you can. What are you using at Hamilton General to get it down?
So the first line drug that we use here is a beta blocker.
Labetalol?
Yeah, labetalol is usually a good medication to get it down, fairly safe. It's available widely, and we use it in the setting of thrombolysis as well to get the blood pressure down quickly.
Okay.
If that itself, and you can give it in aliquot, 10 milligrams repeatedly. If that is ineffective, our second line agent is hydralazine.
Okay.
And that works very well. Now, my experience has been, once you use those two, then you're really looking at a drip, often a labetalol drip or some other agent. And that is when we will call for help from people like yourself, from our colleagues in internal medicine to help us manage the blood pressure.
I'm glad we could be of some use to you as well. Professor Sharma, it's a pleasure to learn from you and to hear your expertise. I appreciate it very much.
Always a pleasure to talk to you.
Thank you.